This podcast contains our own personal views, not associated with any organisation. Coronial contains descriptions of death inquests that may be graphic and disturbing to some listeners. Discretion is advised. Welcome back to Coronial, everyone. I'm Alice.
I'm Emma.
And I'm Georgie.
Today I'll be telling you about the inquest into the deaths of Anna Pennella, Bernard Skeffington, and Graham Jessett, who all died in South Australia after extended periods of ramping, where they had to wait in ambulances under the care of paramedics outside the emergency department of hospitals before being admitted. Anna Pennella died at the Royal Adelaide Hospital on the 28th of April 2019 at the age of 76 as a result of pulmonary thromboembolism due to a left calf deep vein thrombosis. Bernard Skeffington died at the Royal Adelaide Hospital on the 30th of September 2021, aged 89, as a result of aspiration pneumonia secondary to small bowel obstruction. And Graham Jessett died at the Flinders Medical Centre on the 22nd of March 2022, aged 64, as a result of ischemic heart disease with cardiomegaly contributed to by hyperkalemia, which is high potassium. So first of all, we're going to go through each of the circumstances of the deaths. Mrs. Pennella migrated to Australia from Italy when she was 15. She got married and had a daughter and was a nurse for 42 years. She became an Australian citizen in 2015 and that same year went back to Italy to visit for the first time since she had arrived in Australia.
Oh, that's a long time.
Mm. She enjoyed cooking, meeting new people, attending exercise classes, and being a grandmother. She was in generally good health, but suffered from high blood pressure, reflux, and vertigo. On the 27th of April 2019, Mrs. Pennella was visited by her sister-in-law and told her that she thought she had a virus, but that she would be okay. Sort of classic, I'm feeling a bit off, but I'll be fine. One of Mrs. Pennella's friends visited the sister-in-law that afternoon and said she was worried because Mrs. Pennella had been having dizzy spells, so they went together to go and check on her at about 4:30 p.m. Mrs. Pennella said she was feeling cold and was dizzy, so they called the National Home Doctor Service at 5:30 p.m. and requested a doctor. At about 8:20 p.m, a doctor arrived, by which time Mrs. Pennella was feeling better. She had no chest pain, heart palpitations, cough, or fever, and her vital signs were normal. The doctor advised her to visit her GP on Monday and call an ambulance if her symptoms came back. After the doctor left, Mrs. Pennella asked her sister-in-law to stay with her a bit longer, just because she wanted the company and she wasn't feeling great. As she walked into the kitchen, she said she was dizzy and fell, but did not lose consciousness. She was nauseous and vomited 3 times. Her sister-in-law pressed the medic alert button that Mrs. Pennella wore, and the ambulance request came through at 9:15 p.m. with a priority 3.
I am so glad that someone used their emergency button or whatever. I'm so glad that they exist, and I advocate strongly for more people having them.
Yeah, and using them when they need them.
Yeah.
And I think she especially had one because her husband had died suddenly in 2007 and her daughter lived in Victoria. So she was living by herself.
Yeah, she lived alone. I think that's totally reasonable.
Yep.
With those medical alert buttons, do they automatically call an ambulance? Is that...
You can set them up different ways, is my understanding. And don't get me wrong, that does come with different costs. I think... Yeah, I think there's various different versions you can get, various different responses.
A single paramedic was dispatched immediately and arrived at 9:30 p.m. Mrs. Pennella's vital signs were normal, but an ECG showed atrial fibrillation, so the paramedic confirmed an ambulance was needed, which arrived at 9:45 p.m. At the time of dispatch, the paramedics in the ambulance had worked continuously since 2 p.m. without a break.
And what time was that again, sorry?
They arrived at 9:45.
Oh, yeah, okay.
That's a long day.
Oh, yeah.
Without a break.
When the 2 other paramedics arrived, they again took Mrs. Pennella's vitals. Her oxygen saturation was now 86%, so she was provided oxygen. Her blood pressure and heart rate were a little high. The ambulance left the house at 10:18 p.m, arriving at the Royal Adelaide Hospital Emergency Department at 10:33 p.m. When they arrived, one of the paramedics went in alone and queued for about 7 minutes to speak to a triage nurse and provided them with Mrs. Penella's information. She was assigned to Category 3 with a target of treatment commencing within 30 minutes. The paramedic then went back to the ambulance where they waited on the ramp. So data from the health department showed that at 10:40 p.m, there were 87 patients registered in the emergency department of the hospital, which had a capacity of 69 patient spaces and 8 resuscitation rooms.
The math's not adding up.
The math is not math.
Yep. Around 11:10 p.m, so this is about 40 minutes after they arrived at the hospital, the paramedics took Mrs. Penella's vitals again and her condition had begun to deteriorate. Her breathing was worse and her skin was clammy. One of the paramedics stayed with her while the other went into the hospital to get the triage nurse.
And that's such a hard situation where, like, the point of having the two paramedics is to have the two sets of hands, and yet one of them's got to go back and forth. Like, there's no easy communication from within the ambulance either.
Yeah, that's right. The triage nurse came out to the ambulance, and this was the first time that anyone from the hospital had actually visualised Mrs. Penella. The nurse observed her for 30 seconds and noted her to be relaxing, so went back inside.
Right, because we all know 30 seconds of observation is a true representation of their entire... Sorry, I'm being cynical. Like, the paramedics have been with her for...
At least an hour.
It's been 40 minutes since they arrived,
Yeah. So presumably it took them, let's say, at least 20 minutes to get her in the ambulance and get her to the hospital.
They were called at 9:15, the ambulance.
Yeah, they arrived at 9:45, and at this point it's 11:10.
So just over an hour,
And so they're saying at this point she's deteriorated in the time that we've known her over an hour. So I struggle with but then the nurse comes out and sees her for 30 seconds and says, no, she's fine.
Do we know what night of the week this was?
Ooh, good question.
I'm just wondering, because is it general that the weekends are at this time of night potentially a little bit more busy?
Yeah, that was a Saturday night.
Yeah.
Okay, so even worse.
Yeah.
It just sounds like that's a lot of people waiting for services in comparison to the actual capacity. It seems like they've
definitely
that sort of
over
thing would
capacity.
happen, but you would hope that doesn't happen on a nightly basis where they're over capacity every single night.
At 11:16 p.m, Mrs. Penella's condition deteriorated further. The paramedic again went to get the triage nurse, but had trouble finding her since she was with another patient on the ramp. The paramedic with Mrs. Penella increased her oxygen and sat her up. She said she couldn't breathe and her oxygen saturation was 89% on 4 litres per minute of oxygen. The nurse went back to the ambulance at 11:18 p.m. and saw that Mrs. Penella was breathing with increased effort, so increased her to a Category 2 and told the paramedics to bring her into the emergency department. She was wheeled into resus at 11:21 p.m. and was seen by a doctor at 11:30 p.m. About 10 minutes later, Mrs. Penella suffered a respiratory, then cardiac arrest. High-flow oxygen and CPR was provided, and a shockable rhythm was found. She had a return of spontaneous circulation at 11:50 p.m. and was intubated. Her heart rate then dropped and she went back into cardiac arrest, with return of spontaneous circulation at 12:02 a.m. She went in and out of cardiac arrest for the next 40 minutes, before she was declared deceased at 12:39 a.m. on the 28th of April.
To be honest, obviously the outcome is completely tragic, but I feel like that timing isn't as shocking as I thought it would be. So she was ramped for what, like
40 minutes or something? No?
Half an hour?
No, so they arrived at the hospital at 10:33. And she was seen by a doctor at 11:30.
So an hour.
Yeah.
But when she arrived, she was triaged as a Cat 3, which meant she was meant to be seen within 30 minutes. So, like, they doubled her wait time.
I thought it was going to be like, she was ramped for like 3 hours.
Yeah.
But an hour, or less than an hour, I guess, by the time she was out, it doesn't seem as...
And maybe her initial triage category was ultimately probably not correct either, but hard to
Yes.
tell.
Yeah.
Interesting. Okay.
Yeah.
What was her ultimate cause of death again? I can't even remember what her actual underlying issue was.
So the postmortem showed extensive bilateral pulmonary emboli and a left calf deep vein thrombosis.
Oh, okay. But like none of that would have been known at the time.
No.
That was what her problem was.
No, and she had
Like
seemingly no history of this.
yeah, no obvious precipitating factor that was known about.
So the coroner found that Mrs. Pennella should have been assigned to a Category 2 on arrival at the hospital. However, an expert witness concluded that Mrs. Pennella's death wasn't preventable, since even if she had been admitted straight into emergency when she arrived, the amount of time it would have taken for testing and diagnosis meant that she wouldn't have started treatment until she deteriorated. So in her case, the time frame was that it would have been the same outcome whether she was on the ramp or in the hospital, most likely.
Yeah, and also like she was still with a paramedic, so the concept of her deteriorating, they were still able to apply oxygen. They were still able to do some intervention in the meantime. So it wasn't like she was sitting in a waiting room without intervention, deteriorating without some medical assistance.
Yep.
And a question about like the handover of care between paramedics in the hospital. So it sounds like when a patient is ramped, they're technically still under the care of the paramedics. Is that correct? And then it's not. Oh, okay.
I had this in here later, but I'm going to talk about it now.
Yeah.
Are you saying it's a grey zone?
Yes.
Yeah.
So they did discuss in the inquest who has duty of care and responsibility over ramped patients. And it was found that there wasn't a South Australia health policy which specified that. It was noted that Queensland's policy clearly says hospitals assume overall responsibility for patient care from the time of triage.
Interesting.
So in Queensland, it's from triage, but South Australia, they're like, we don't know.
Because, yeah, practically speaking then in Queensland, then theoretically could the paramedics just leave them? Oh, no, they need their equipment though. But I'm just thinking it also just seems like such a waste of the paramedics' time.
Yes.
Sitting there waiting for hours with a ramped patient when there's probably so many other people who are experiencing emergencies that they could be dealing with. But I also understand that happens.
Imagine what happens when they transport patients that end up being Category 4 or lower.
Yep.
Then they're sitting there with a completely well patient just being like, I would like to go
At that point, can't they just be like, with your broken finger? Oh, surely you wouldn't call an ambulance for a
broken finger. But
I mean, you might.
But realistically, you could, If it's a broken ankle, then you can't drive yourself.
Yep.
Or get a cab or whatever.
Like, I think you can put them in the waiting room if there's like appropriate caveat of circumstances. But I don't know those.
Yeah, no, that's fair. It's just, it seems like a system that's not fantastic, but I'm not close enough to the system either to say whether there's any, potential easy solutions. And I'm assuming there's not, because otherwise
it wouldn't be so much of a problem.
Yeah, exactly.
Okay, so that's Mrs. Pennella's story. Now we'll move on to Mr. Skeffington, who moved to Australia from Ireland when he was 18. He worked in the mining industry before being injured in an explosion.
As
there was
you do.
No other information given about this explosion.
I do need more info, but that's okay, coroner.
Yeah,
you can work on that.
Well, it was actually from the family's statement to the court that it mentioned this, because they included that at the end of the inquest.
Okay.
So he lived in WA when that happened. He went to Adelaide for treatment for his injuries and ended up staying and meeting his wife. He then worked at General Motors Holden. After he retired, he enjoyed spending time with his children, grandchildren, and great-grandchildren, and he was involved in charity work. He was also still quite fit and able for someone who was 89. Like, he would take out the bins in his residential village for people who were not able to take their bins out.
What a cutie.
Yeah. At 9:53 a.m. on the 25th of September 2021, Mr. Skeffington's wife called an ambulance because he had stomach pain and was vomiting. And she said he had previously had a twisted bowel. The call was initially assigned as priority 5 and then quickly upgraded to priority 3. An ambulance was dispatched at 10:04 a.m. but was reassigned to a suspected stroke. An extended care paramedic called Mrs. Skeffington back at 10:31 a.m. to check in. She said that Mr. Skeffington had taken an anti-nausea tablet at 8:30 a.m. and his vomiting was starting to ease. And she also said that his previous twisted bowel episode had been 2 years before, and he didn't have any problem opening his bowels that morning.
So he took a shit that morning.
I just love that the paramedics need to ask that.
They do. And
Well,
I
they do,
also
yeah.
love married life or, living with someone
Yeah.
life where you're like,
Yeah, he
know all
definitely
the
did that.
answers.
Yes. At 12:06 p.m, another ambulance was dispatched, but again was reassigned. An extended care paramedic again called Mrs. Skeffington at 12:29 p.m, and they advised the wait time was 90 minutes. A third ambulance was dispatched at 12:39 p.m, but it was also reassigned.
How many hours has it been? And they're like, oh, just be another 90 minutes. And you're like, yeah, but
Yeah.
you said that 4 hours ago.
She called just before 10 a.m.
Yeah.
Whereabouts do they live? Are they like a little bit rural or what's going on?
Oh, no, these are all in like
They
metropolitan.
went to the RA or Flinders.
yeah, but like...
They can't be that far away.
Let me tell you.
And what day of the week is this?
So he lived in a retirement village at North Plimpton,
Oh, okay.
That's
Yep, cool.
not far out at all.
and it was a Saturday.
That's weird.
That's odd.
Yep.
What's going
It was
on?
September 2021.
Yeah, okay, that makes more sense.
Okay, so it's COVID.
Don't know what else was going on apart from that. At this time, Mrs. Skeffington advised that her husband had not vomited for a while, was tolerating small sips of water, and was sleeping. At 1:25 p.m, a fourth ambulance was dispatched, and this one arrived at 1:36 p.m.
Success.
Yay.
Woo!
Mr. Skeffington was alert with abdominal pain and a rigid abdomen. He was given anti-nausea medication and placed in the ambulance to be taken to hospital, arriving at the Royal Adelaide Hospital at 2:18 p.m. Data from the hospital show that there were 20 presentations recorded in the same hour Mr. Skeffington presented.
Oof, that seems a lot.
There were 20 presentations in the hour before that, and 22 presentations in the hour before that.
That's
Busy.
that sounds busy, yeah.
Yeah. The ambulance had to be parked far away from the emergency department entrance because of how busy it was.
What's going on?
Yeah, that seems silliness. Also, this is a moderately new, moderately expensive hospital. Are you saying that there wasn't enough parking for ambulances?
Not when you've got however many ramped. Like,
Yeah. True.
if all of the people from that hour that he arrived, all 20 of them
Are
have to be
ambulances,
ramped.
yeah.
That's not much. The ambulances take up quite a lot of room, don't they?
Yep.
At 2:24 p.m, Mr. Skeffington was assigned triage category 4 and was also not visualised by the triage nurse. While waiting, Mr. Skeffington fluctuated between being comfortable and being distressed. He was given more anti-nausea medication at 3:10 p.m. One of the paramedics went into the hospital to speak to the triage nurse, and they came outside to see him. He had one hand on his abdomen and was grimacing, but was chatty and sitting upright. And I think this was in one of his periods where he was a bit more comfortable
Yeah.
rather than being distressed.
Okay.
The triage nurse said that they would try to bring him in and changed him to a category 2, but there were no pending discharges and no space in the department. Mr. Skeffington began vomiting again and deteriorated. At 3:40 p.m, the paramedic again went inside to let the triage nurse know. The paramedic who remained gave Mr. Skeffington another dose of anti-nausea medication with no effect. Mr. Skeffington had an explosive vomit, which the paramedic thought was a fecal vomit. He became unresponsive, rigid, and bradycardic. The paramedic struggled to sit him forward to prevent aspiration and also couldn't reach the radio to alert the other paramedic, instead banging on the windows of the ambulance to attract attention. So, because they were in there alone, because the
Yeah.
other paramedic had gone into the hospital.
Yeah.
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 Another paramedic from a nearby ambulance came to help, and they unloaded Mr. Skeffington to take him inside. That paramedic gave evidence at the inquest that was quite a traumatic time for them because they were alone in the ambulance with this patient who's all of a sudden
Like significantly
very
deteriorated.
ill. Yeah, and
Yeah.
they're trying to like sit him up to stop him from aspirating, but I don't know whether he was still strapped in to the bed at that point or like, yeah. Mr. Skeffington was taken into the emergency department at 3:48 p.m. and his care was transferred at 4:01 p.m. He was not conscious, was blue-grey in colour, and the paramedics were sure that he had aspirated. His oxygen saturation was 70% and his pulse was weak. He was provided oxygen and was stabilised, but then started vomiting again, so a nasogastric tube was placed. He was diagnosed with a small bowel obstruction, but the main problem was the aspiration, which was confirmed by a CT scan.
Which he didn't have until he got to the hospital.
Yes.
Okay.
Yep. His bowel obstruction had resolved by the morning of the 27th of September, but he had ongoing respiratory issues with a cough and wheezing. On the 30th of September, he had reached the maximum level of respiratory support. By that afternoon, he continued to deteriorate, so decided to transition to comfort care and died within a couple of hours.
Oh, okay. Right. He's 80 something.
He's 89.
Sorry, because you said maximum respiratory care and I was like, oh, so is he going to get intubated? But he's elected not to get intubated.
Correct.
Okay.
Yeah. So I think on that morning of the 30th or maybe the day before, the doctors had sort of told him this is the most we can do. And he was like, no, I'm like, let's.
I got this.
I'll keep trying.
Yeah.
But then by that afternoon,
he was like, no, I don't got this anymore.
Yeah.
Okay.
His death was confirmed to be due to aspiration pneumonia secondary to small bowel obstruction. The coroner found that Mr. Skeffington should have been assigned to Category 3 on arrival at the hospital, but that this may not have resulted in him being seen sooner, considering how busy the emergency department was. The head of the Royal Adelaide Hospital Emergency Department at the time of his death gave evidence at the inquest that on this day, the hospital was essentially running two emergency departments, a COVID one and a non-COVID one.
Yeah, okay. Yeah.
So that just complicates matters even more.
So much. Yep, okay, that makes a lot more sense in terms of those delays.
Yep. The coroner also found that Mr. Skeffington's death was preventable, since if he had been assessed earlier and a nasogastric tube placed earlier, he likely would not have aspirated and the bowel obstruction in itself was not life-threatening.
Can paramedics place nasogastric tubes?
Don't think so.
Yeah, okay.
As far as I'm aware, they can't.
Yeah, okay.
Otherwise, I feel like they probably would have just done it.
Well, that's my question of like, therefore the ramping gets blamed, but if we had a paramedic that could have done it, would they have? And this is my question of like, he likely would have had the nasogastric tube earlier. Well, would he have? Or was it not until he had that deteriorating event where he started aspirating would they have actually placed it?
Yeah.
Anyway, sorry. Logistics and the coroner's like, nah, he probably would have got it earlier. So I'm like, okay, they've got more info to trust that.
Yeah.
But yeah.
Yep. And so that's Mr. Skeffington's story. We don't have much background information on Mr. Jessett, other than he lived in Adelaide with his wife. He had an extensive medical history, including type 1 diabetes, 2 previous heart attacks, high blood pressure, renal impairment, gout, coronary artery disease, congestive cardiac failure, ischemic cardiomyopathy, and chronic pulmonary obstructive disease.
Did anything work still? Or
Yeah, Emma's tapped out of his medical history. She's like, nah.
He sounds like he's having a rough time.
Yeah, and he's 64.
Oh,
wow.
He's the youngest of the three of them.
Okay.
But the
Gosh, he must have had a hard life.
least healthy of.
Yes,
Yeah.
of the three of them. Yep.
And when you've had 2 heart attacks in your life, like,
Yeah, your heart's not doing
Yeah.
well. Yeah. In mid-February 2022, Mr. Jessett was diagnosed with shingles, and on the 11th of March, he tested positive for COVID.
Ah, jeez. Poor thing.
he's one of those people that you like absolutely do not want getting COVID.
Yes. Yeah. On the 19th of March, he was still feeling unwell, so his wife called an ambulance. They attended, but Mr. Jessett was not unwell enough to go to hospital, so they advised him to take paracetamol, drink fluids, rest, and contact his GP. At 10:48 a.m. on the 22nd of March 2022, so 11 days later, Mr. Jessett's wife called the ambulance and reported that he was full of fluid, had chest pain, was pale and clammy, lethargic, and not breathing normally. I'm not entirely sure what she means by saying he was full of fluid. Like, was he coughing?
Swollen?
Was he swollen?
Yeah, I would assume it's swollen. So his heart doesn't function very well. And so I assume did you say he's got cardiac failure? Is part of his...
he had a lot
Yes.
of
Congestive cardiac failure.
Congestive cardiac failure. When your heart doesn't work, it then doesn't pump fluids appropriately around your body, and so then you end up with fluids pooling into tissues, typically related to gravity,
legs.
so the bottoms of your lungs, your legs, which are typically lower than the rest of your body.
So Mr. Jessup was assigned to priority 2. An ambulance was dispatched at 10:57 a.m. and arrived at 11:01 a.m. The paramedics found him uncomfortable rather than in pain, with a distended abdomen and mild shortness of breath when sitting up. They were concerned about his recent COVID infection worsening his existing congestive heart failure. The ambulance left at 11:30 a.m. and arrived at Flinders Medical Centre at 11:46 a.m. The emergency department there exceeded its capacity in the hour before Mr. Jessup arrived, and 38 of the 67 treatment spaces in the department were occupied that day by admitted patients waiting for a bed on wards. There was also a lot of talk here in the inquest about the fact that he had recently had COVID. And there was some mixed information about when he was diagnosed and how, meaning that he was noted as needing COVID precautions, and there were then fewer options for him to actually get into the department. I think there was only like one room available that he could have gone into. Yeah.
And at that time, it would have been, really challenging to work through, and everyone having the right precautions on and all that kind of stuff.
Yep. So the paramedic had to wait about 12 minutes before speaking to the triage nurse, who was not able to visit Mr. Jessup in the ambulance and assigned him a triage category 3. While waiting on the ramp, Mr. Jessup had sudden onset epigastric pain, which was somewhat relieved by sitting up and burping. I enjoyed that little tidbit there. The paramedic went inside to report this to the triage nurse, who noted it but did not go out to see him. Mr. Jessup was given paracetamol at 1 p.m. and didn't complain of further pain. At 3 p.m., the paramedic noted that his observations were generally normal, and since he had been stable for 3.5 hours, turned the cardiac monitor off so Mr. Jessup could be more comfortable. While they were waiting, only one patient on the ramp was transferred to the waiting room. So that whole 3.5 hours that they were waiting, everyone else
was still waiting as well.
Still waiting.
No one was moving.
Yep. At around 4:47 p.m., so that's... They called the ambulance at 10:48 a.m., so that's 6 hours after they first called the ambulance.
Yeah, okay.
And 5 hours since they arrived.
Wow.
So he's been wrapped for 5 hours.
Yeah, okay. These are starting to get to the numbers that we were expecting.
Yeah.
And he's a moderately sick individual from a, he's got
a
all this extra
pre-existing
history.
condition. Yeah.
Versus the other two, it's like, you may not have necessarily expected to see them deteriorate in such short periods of time. Versus this individual is absolutely the one where you're like, they will deteriorate in a second.
Yep. So at about 4:47 p.m, Mr. Jessup was able to be moved into the emergency department. He was wheeled in and then asked if he was okay to walk a few steps to the hospital bed, which he agreed to. He became unsteady while doing this, and when he sat down on the bed, he collapsed and went into cardiac arrest.
That's okay. Okay. Yeah, I was like, this is going to be bad that they've asked him to walk, and I'm like, I wasn't wrong.
Yep.
Okay.
CPR began and he had return of spontaneous circulation after 2 minutes and was intubated at 5:05 p.m. At 5:22 p.m, his oxygen saturation worsened and he had no carotid pulse, so CPR was restarted. At 6 p.m, Mr. Jessup was found to have a non-shockable rhythm and the decision was made to stop CPR. The postmortem found that Mr. Jessup's death was due to ischemic heart disease with cardiomegaly, which is a big heart, and that hyperkalemia, hypotassium, played a role in his death.
I wonder if just the hypotassium's as a result of a lot of the other interventions that he's had. The CPR and stuff.
Does hypotassium, that has a pretty bad effect on your heart, doesn't it, generally?
Yeah, it's not great for it.
Yeah, and he clearly already had a heart that was having
Not
trouble.
ideal.
Yeah.
So in terms of the COVID infection that I talked about earlier, the coroner did note that because the departments are already really busy, and then there were some clinicians that gave evidence that his COVID status didn't actually deny him earlier entry necessarily.
Okay. Yeah.
There was also discussion about Mr. Jessett's diabetes and whether his abnormal blood results were due to diabetic ketoacidosis or an exacerbation of diabetes due to his illness and the worsening renal function. However, the expert witness noted that even if insulin had been provided to Mr. Jessett, it wouldn't have reduced his potassium levels enough to have prevented his death.
Okay. Yeah, right. So they're just saying it'd have an effect on his potassium maybe if he'd been treated for his diabetes.
Yeah, but not enough to make a difference.
Yeah, okay.
Once again, the coroner found that Mr. Jessett should have been assigned to a Category 2 on arrival at the hospital, but again, it may not have changed the outcome, considering he was also flagged as needing isolation. The coroner found that Mr. Jessett's death was potentially preventable if the hyperkalemia had been identified earlier. So now we'll start talking about the general ramping issues that the coroner talked about in the inquest. So the coroner noted that ramping is most often caused by access block and exit block. Access block is where patients are unable to be moved from the emergency department into hospital wards, meaning that they wait in the department even after they've been stabilised and their treatment has been started. Exit block is where patients are unable to be discharged from the wards back into the community, meaning they stay in hospital even when they don't need hospital-level care. The community-based deficits here are the aged care and disability care facilities, as well as limited beds in mental health facilities. Exit block leads to access block, which leads to overcrowding, meaning that the newly arrived patients can't progress into the department and instead wait in waiting rooms or in ambulances outside the hospital.
And then you get emergency staff that are no longer really tending to emergencies, but running a whole new in-hospital inpatient ward.
Yeah.
Yeah.
Yeah, they're no longer like, this person urgently needs our help. It's
this person.
We've started them on treatment.
What would you like me to do now?
Yeah. Something else which contributes to exit block is the concept of the 9-to-5 hospital.
Absolutely.
All public hospitals in Adelaide provide 24-hour-a-day, 7-day-a-week care. However, this varies between departments. The emergency department requires senior doctors to work a 7-day roster, but other departments don't. This means that patients on wards may be ready to be discharged on a weekend, but there is no senior doctor there to order their discharge. And so they stay in the ward, which means someone from the emergency department can't go into the ward, which means people from the community can't get into the emergency department.
I like that this is still a problem in 2025.
Yep.
Yeah, the concept of not being able to discharge someone after hours is ridiculous.
So a solution to this has been implemented at one hospital, where they now have the Supportive Weekend Interprofessional Flow Team, or SWIFT.
Oh, that's cool. Okay, so then it's like a cross team so that it doesn't rely so heavily on one single individual being available. Oh, that's cool.
So it's a multidisciplinary team which meets on weekends to identify bottlenecks in discharges and coordinate discharge where appropriate.
Cool.
And the example the coroner gave was there might be someone who needs a physio assessment to be able to be discharged.
Yeah.
So they arrange for that physio assessment to be done on the weekend so they can get discharged.
Yeah. Yeah, nice.
So other contributing factors to ramping include an increased prevalence of chronic health conditions in the community and a reduction in access to GPs because of a decrease in bulk billing and a general decrease in the number of GPs.
Topical.
Interesting. I didn't know there was a decrease in the number of GPs. I wonder what that is. Is it
No
just
one
a
wants to be a
profession
GP anymore.
people don't want to do?
The coroner also looked into the consequences of overcrowding. The most obvious cohort affected are patients, not only those who experience ramping, but those who are treated in overcrowded emergency departments, those in the waiting room, and potential patients in the community waiting for an ambulance. There is also an impact on health staff, across the board, with many leaving jobs or the industry entirely because of the pressure and stress caused by working in an overcrowded department.
Absolutely.
The coroner discussed the changing demand on the South Australian health system. There are now fewer triage Category 5 and 6 patients and more Category 2 patients, likely due to an ageing population and the increase in chronic health conditions.
I find that interesting that those are the two reasons. Is it also not because, like, I think South Australia has done pretty well in implementing, like, urgent care facilities that are meant to...
You read my mind.
Are you about to talk about this? Oh, sorry.
So there are now also more options for lower acuity patients to access healthcare. So, for example, in Queensland, we have satellite health centres which treat minor illnesses and injuries that aren't life-threatening. This means that patients presenting to emergency departments are in a more serious condition and are there for longer. The lack of low acuity, quick turnaround patients means that healthcare staff are faced with one complex case after another, which results in mental pressure and stress. The South Australian government also expanded the ambulance service, which the coroner recognised as a very good safety initiative to make sure people in need of urgent care are under the care of a paramedic sooner. However, this increase in patients being transported to hospital has a flow-on effect on emergency departments, which haven't necessarily also been increased in size.
Yeah. Okay.
When discussing the culture of South Australia Health, the coroner highlighted one example, having blood tests taken from patients who are experiencing ramping. As noted in Mr. Jessett's case, if his hyperkalemia had been identified earlier, his death may have been prevented. While there was some concern from people who gave evidence about practical things, like who would be responsible for reviewing the results when a doctor hadn't yet been assigned to a patient, there was active resistance to the idea of the paramedic scope of practice being extended to taking a blood sample. I don't know whether that was to do with they didn't want to train them to do that. They didn't want them to have
to put a cannula in,
Yes,
which is the same
yeah.
thing. It's
Maybe they
probably
didn't-
again to do with the whose responsibility is it to chase the test, because once you have taken it, in theory, you then have the responsibility, and so then who do you hand that over to?
Yep. So there was a few comments like that, and there was also the thought that a normal blood test result would lead to a patient being ramped for longer.
Fair, yeah, that's true.
Yep. So the coroner had a straightforward solution to this, and this coroner was very straightforward, which I really enjoyed. So a procedure where the results of ramped patients' blood samples are not reviewed by the triage nurse or intake doctors unless they are highly abnormal, and rely on the processes already in place where highly abnormal results are flagged by the pathology unit.
Yeah, okay.
Mm-hmm.
This means that a patient like Mr. Jessett would have been identified early, and for those with normal blood test results, then they're just on file, available for the doctor to view when they do eventually take care of that patient.
And very helpful when they're already sitting there, because then you're like, perfect, I've got this extra bit of information already available to me without needing to wait another hour or two.
Yes, exactly.
Yeah, nice.
And I'm just going to include a quote from the inquest here because I just really enjoyed it. In reality, this is merely an issue of implementation that needs to be worked out. However, instead of working towards an appropriate manner of trying this initiative, the response to this proposal was to strongly disagree. The enormous benefit of potentially picking up a patient who is about to lose their life on the ramp is lost amongst arguments about scope of practice, the traditional role of paramedics, and ramping figures. That is unfortunate.
Yeah, that's well worded.
Yeah.
Yeah.
It's sort of like everyone needs to stop arguing about small things and just look at the bigger picture of, okay, could this help people? Yes.
Well, I think that's also the thing, right, of the coroner's coming at it from, I guess, a justice perspective here of, like, we should all receive the same level of care no matter where we are, be it on the ramp or in the hospital, etc. But those that are in healthcare are so, like, siloed away in that space that they forget to see that bigger picture.
Yeah, the coroner's definitely looking at this holistically.
Yeah,
sure.
yeah. In a very different lens to those in healthcare.
Yep. The coroner also discussed the attitude that directly addressing ramping is a misdirection of resources. And again, I'm going to include a quote because it was great. Various witnesses described initiatives addressed at the symptom of ramping as band-aid solutions. In many respects, the witnesses were oversimplifying the positive effects of the proposed initiatives and undervaluing their potential benefits. Dismissing efforts at improving safety as band-aids is reductive and unhelpful. I discourage it.
Very good.
So the coroner also heard evidence about the current initiatives to reduce ramping. So outside of the hospital environment, there are the following initiatives. Expansion of the ambulance service, which I already mentioned. The use of extended care paramedics who make higher level clinical decisions and treat patients rather than transporting them to hospital.
Yep.
Where appropriate, obviously.
And where available, because
Yeah.
I guess they'd be limited. Yep.
Yeah. Virtual care services, which uses video calls between patients and clinicians. 5 primary care centres, which are operated by GPs in locations with other services like pathology, radiology, and pharmacy, with support from emergency and acute care trained nurses. These are not GP clinics, and a referral is needed from another health service.
Oh, so they're not walk-in?
No, not
walk-in
walk-ins,
services.
no. There's also 5 urgent care centres using existing facilities which provide care for walk-in patients unable to wait for their usual GP, and that's a Commonwealth Government initiative. Yeah. There's also an urgent mental health care centre. 3 pharmacies were extended to 24-hour services.
Oh my God, yes.
And a new older persons emergency review and assessment service with the aim to keep people over 65 years of age in their home and out of emergency departments.
I was about to ask you what an older person definition was.
Yeah, I was thinking the same
65,
thing.
which
That's defined by someone other than us.
yes, it is. And inside the hospital environment, hospital ambulance liaison officers called HALO paramedics. I did like that
I love all
acronym.
these acronyms, yeah.
Stationed at the triage area to support and facilitate communications between hospital and ambulance staff. Multidisciplinary teams with an aim of reducing avoidable hospital admissions from within the emergency department.
Yeah.
Sorry, were you going to say something about the HALO paramedics?
It's frustrating that there needs to be like an additional communication staff just to like communicate between 2 people of like a similar profession. But anyway, that's fine.
South Australia Health has committed to introducing consultant-led rapid assessment and treatment models of care. The statewide interfacility transfer system has been mandated for most patient transfers, whereby a patient's assessment is shared between hospitals before moving the patient, which means they can bypass the emergency department and be admitted directly to a ward.
Yeah, if they've come from a ward and they're going to a ward, why would they need to go through an emergency department?
So I think previously they did have to. But now they just talk to each other and say, yes, we're happy to take this person straight to the ward because of we know all of their history.
Yeah.
The SWIFT, which was mentioned before, to increase weekend discharges. The Geriatric Emergency Department InReach project has embedded specialist geriatric expertise within the emergency department.
Oh, that's cool.
A medical assessment and planning unit was established adjacent to the Lyle McEwen Hospital Emergency Department, which deals with patients who are expected to be discharged within 24 hours with a view to identifying appropriate out-of-hospital services. A Q zone, again at the Lyle McEwen Hospital, an area with 10 spaces for ambulance arrivals with 24-hour, 7-day nursing staff. So 2 dedicated ambulance offload assist nurses and 1 ambulance triage nurse. So patients arriving by ambulance are brought to this area and will wait on a hospital bed in the care of the paramedics until their care can be transferred to the nurses who staff the area.
Okay, cool.
So it's kind of like a waiting room, but
it's
for people who
does
need.
that free up the paramedics though?
Yes.
Yeah.
So they may still need to be waiting there with their patients, but when the nurse is able to take their care, then the nurse does.
Yeah.
They're in the hospital setting and
freeing up the paramedics. Yeah. So it's an attempt at helping with ramping.
Yeah, absolutely.
Yeah, cool.
And a transit lounge, at the Lyle McEwen Hospital, where patients who are ready to be discharged from wards, but there's a delay. So, for instance, they're waiting for a family member to pick them up. They can go to this transit lounge where they're still, I guess, able to be visualised, looked after to some extent, but
they have
waiting.
Like big hospital chair things. You know, they're kind of like semi-treatment chairs or like what you might sit in for like donating blood or dialysis.
Yep. You could
They're
have
very
one
common
nurse
now.
with a whole bunch of patients
That are
who
in
all
theory
well enough.
well,
Yeah,
but
to
they still
leave.
technically get a set of obs every however many hours that they're sitting there.
Yep.
You still need to make sure that they are well while they're in the hospital building, but realistically they're going home, so the chance of that happening.
South Australia Health has also started to make better use of data. The rollout of a single statewide electronic medical record has enabled live analysis of patient-level data. They've also established the State Health Coordination Centre, the SHCC, which has brought about system-level oversight and navigation. The SHCC works with the network operations centres of each local health network to improve patient flow and to identify where system-level cooperation is required to facilitate patient care. A mechanism of ramp control is now used to ensure that no individual hospital is overrun with demand at times when others are less pressured. And that was an interesting one with Mr. Jessett's case because he was clearly stable enough to be ramped for 5 hours, but wasn't deemed well enough to be taken to a different hospital where he may have been seen sooner because he was waiting at the Flinders Medical Centre, which only had one isolation room for him.
Yeah.
Could they have taken him to the Royal where they had more
isolation?
Yeah.
And that is a very specific to COVID instance.
Yes.
But it's really uncommon for people to be taken from one hospital to the other as well.
Yeah, once they've arrived
at a hospital. Yeah,
been
is my
triaged.
understanding.
Yeah.
Because the assumption is every other hospital is equally as
Yes.
busy, but I
now
suppose
they're
moving-
actually checking to see whether every other hospital is
as busy.
Yeah.
Yeah. And especially in Adelaide where it's such a small location. So the time difference between those two
It's
hospitals
not too
is
bad, yeah.
nothing.
It's not 5 hours.
Yeah. Yeah.
Yeah.
It's far less than 5 hours.
Yeah. While the coroner found that South Australia Health's response to ramping is comprehensive and well thought through, ramping is still an everyday occurrence. In January 2025, 3,479 hours was spent on the ramp across the network, which is an average of more than 112 hours every day.
That's ridiculous.
Yep. The coroner acknowledged that there is no simple solution to ramping, and they had to focus on recommendations which will make the process of being ramped as safe as possible.
Yeah.
We're not going to be able to get rid of it entirely.
Yeah, because
especially not in the short term.
Yeah, the only way to get rid of it is to have more hospital beds, and they don't just pop up.
Yeah.
No, and then with an aging population as well.
It's only going to get worse.
It's going to get worse and worse. So, you get more hospital beds to meet the demand at this point in time. It's just going to increase.
Yep.
As we move further along.
So now we start to get to the recommendations, of which there were a lot.
Strap in.
Yeah. So recommendation 1, that the South Australian government formally acknowledge that ramping is a reality that all modern healthcare systems encounter. While efforts to reduce the levels of ramping remain extremely important, efforts must also be made to make the process of ramping safer for those patients who will inevitably experience it. There was some opposition to this recommendation that was noted in the inquest, to which the coroner responded, and I quote, "I still consider that a public statement is the necessary first step to moving beyond a paradigm where so much effort and energy is wasted on discussing ramping figures instead of actually focusing on improvements to the ramping process." Because there was also a fair bit of talk in there by the coroner about the media and the role that they have played in sensationalizing the ramping figures. Making people afraid of ramping without
understanding
what is actually that goes into it,
problematic about it versus sitting in any other waiting room.
Yes.
But also, could you be sitting in a waiting room? But again, obviously most of them, the answer is no, because that's why the paramedics are still there.
Yeah.
Yeah.
And actually, that almost sounds safer, having a paramedic chilling with you.
But then you're taking the paramedic away from other people.
Yeah, I know. I'm not
saying
there's issues with it, but I'm saying from a patient perspective, I wouldn't be mad.
Yes, I agree. But if you could be waiting in a hospital, in the emergency department, around all the people who are specifically trained to help you.
Yeah.
Paramedics do have a specific scope.
They do, but
the gentleman who only needed a nasogastric tube wasn't able to get a nasogastric tube. And in theory, that's a relatively simple procedure.
Yeah.
That, yes, they have very good skills. Yes, they have oxygen. Yes, they know how to do CPR, but they're still not there to be a secondary hospital.
Yeah,
That's not
that
the
is
purpose.
True.
Yeah, they're not there to treat you. They're there to stabilize you and get you to hospital.
Yeah.
Yeah.
Whereas the people who are there to treat you are all inside the hospital.
But
Too
hey,
busy
like,
with too many other people.
I still think it's better than the alternative of needing
of being at
care
home
and
and-
actually, yeah,
Yeah.
exactly.
Yep.
But yeah, I think the media definitely plays a role of sensationalizing and being like, if you're ramped, like these are all the things that could potentially go wrong. It just isn't very helpful
Yeah.
to the whole situation where like you are still in an environment where you are really almost as safe as you can be. And also I think we sometimes lose sight of the fact that we live in a very privileged society where we have access to these things as well. So yeah.
Yep. Recommendation 2. A statewide policy should be introduced requiring visualization of patients arriving for triage, regardless of their manner of arrival, in line with the Australasian Triage Scale Education Kit. Additional resourcing for triage nurses may be necessary to achieve the requirement in practice. The policy should allow for each hospital to decide the manner in which visualization occurs. The policy should be kept up to date with best clinical practice. And I think that resulted from the fact that all 3 of the people who died were not visualized by the triage nurse when they arrived. And potentially that would have changed the triage category they were assigned when they arrived. Recommendation 3. South Australia Health should review the staffing model and workload of triage nurses at metropolitan emergency departments, with a view to identifying tasks which may be appropriately carried out by an administrative support person assigned during times of peak demand to assist triage nurses.
Mm-hmm.
This review should consider the costs and benefits of an increase in administrative staffing per shift versus an increase in triage staffing per shift. The review should take into account any applicable workplace agreements. The review should be consultative and consider the full impact of any proposed changes. That one makes sense.
Yeah,
Solid in
straightforward.
theory, I wonder in practice, like
Yeah,
actually
yeah.
getting people to
Yeah.
want to do that job. But anyway.
Yeah.
And finding a nice consensus across the consultations. But anyway.
But, you know, as I said, good in theory.
The coroner heard evidence about triage handovers and the content of triage notes, since there were found to be differences between the notes of the paramedics and the triage notes recorded by the triage nurse. South Australia Health advised that a new digital patient clinical record is being developed, which will integrate with the statewide electronic medical record, so that a patient's observations from the paramedics will be transferred and recorded in the hospital's record.
That's good.
I had assumed that was already a thing that was in place, but clearly it is not.
No. They print off their record to leave in the patient's chart when they're in the hospital, and then the paramedic leaves. And so you just like take what's on the triage as what happens, because no one uses paper anymore and the hospital records are all digital and technology doesn't always align. So you
Wow.
Yeah. Sorry.
We're in 2025 and that still is not. Clearly they're working on it, but cool.
Again,
that's great.
All of these are my past experiences.
Yeah.
Don't know how real they are now, but clearly. Yeah.
Yeah, there's still something to it. So the coroner still provided recommendation 4, which is that a statewide policy should be introduced mandating the use of a structured oral handover between paramedics and triage nurses.
Is there not?
Yeah, would you?
Apparently not.
All
In
the
South
TV
Australia.
shows I've watched. That's the main method of communication. Anyway.
Yes, but I think there was some talk, I think it was Mr. Jessett's case, where potentially the type 1 diabetes either wasn't discussed between the paramedic and the triage nurse, or like it was in the paramedic's notes but not in the triage nurse's notes, and
Right, and in the context
know.
of the potassium and all that.
yeah.
Yeah, it was important.
Yeah.
Yep. So there's no current standardized practice of paramedics being informed of the triage category their patient is assigned.
Wait, what?
Ah.
Okay.
So, although some paramedics do ask the triage nurse, and sometimes this information is provided.
What?
Yeah.
So you're saying they'd be like, sorry, what category are we? And the nurse be like,
I
"Go
can't
away
provide
now."
you with that information. I'm sorry. What kind of confidentiality exists
Or
in
the
that
paramedic
circumstance?
doesn't ask, and they're not told. Like, it's not routine for them to be told. I can't remember what the discussion about this was.
That implies like the nurse, if is asked, doesn't necessarily have to give the answer.
That's what I mean.
And I'm
Well,
like, can
not-
you imagine just being like, no, I'm not going to tell you.
Yeah, I don't understand what the confidentiality is there.
No, it's not confidentiality. I think it's to do with if they know, then they can try and influence the triage nurse to be a different category.
That doesn't make sense to me.
No, it's in that hierarchical type siloed thinking that I'm the
triage nurse.
nurse.
This
I'm
is
the one
my
who
job. I
decides
know better
this.
than you.
Yes.
Like,
you don't have any input. I know.
But equally,
and they do
it's mostly
know what else
protocolized.
is-
So like,
Yeah.
there's not really that much you can do to influence it.
yeah, that's what I mean.
But
Like,
having that discussion means that like the paramedic might be like, oh, but did you catch that I said he has poorly controlled type 1 diabetes? Have you taken that into consideration? And then you have an open conversation.
yeah, and it also helps manage the expectations of
Yes.
the patient as well. I know that that's not top priority, but to at least say,
You're a category 6. We're going to be here for a while.
We're going to be here for a while. And again, that will help them reassess.
Yeah, I just can't believe that people might be like, no, I'm not going to tell you.
That just is ridiculous.
That's petty.
So because of that, the coroner made recommendation 5. A statewide policy should be introduced with, or an existing policy amended to include a requirement for triage nurses to advise paramedics of the triage category assigned to each patient who is not immediately brought into the emergency department. Yeah. So it'd be for the ones who are ramped.
Yeah,
which makes sense.
If you're coming inside, you're dropping off the patient, and you're like, bye.
Yeah, you don't
Yeah.
really, it's not your job to know what the category is. Yeah.
I wonder if with that over time, it'll adjust as well to notifying you the category and the average current wait time for that category.
Yeah, possibly.
That would be so helpful.
Yeah, because just because you're a category 3, it says you're meant to be seen within 30 minutes, but what does it actually mean in practice?
Yeah. Recommendation 6, that a trial be undertaken of blood samples being taken from patients waiting for emergency treatment in metropolitan hospitals following triage who are anticipated to wait on the ramp beyond their Australasian triage scale target timeframe, with the usual processes applied for the review of results to detect and raise alarm about results which indicate that the patient is at imminent risk of death. A review should be scheduled at the end of the trial to determine whether there were any unexpected negative impacts, with consultation of those involved. And like, this seems like something the coroner was really strong on, that like, why don't we trial taking blood samples? Like, there was a lot of opposition to it. And the coroner was like, how about we just give it a go and see whether it has any positive impact?
I'm trying how the practical nature of that would happen. And I'm not, like, I agree, I think it's a good idea, but I can see why people are like fighting back against it, because it's like, you're saying only if they overstay. So it's only, say, a Cat 3 needs to be seen in 30 minutes. You're saying
if the expected wait time is more than 30 minutes.
Okay. So,
yeah.
okay.
So it's not like you wait
to 30 minutes and you're like,
no.
Okay, time for blood. Yeah. But then also the paramedic's not an employee of the hospital. So it's like, once they take that blood, they then still have to hand it over to an employee of the hospital.
Yep.
And it's that whole like duty of care in terms of like the person that's on the ramp versus the nurse. So then who would...
Yeah, there's going to be additional procedural steps involved with the whole thing for sure.
But it's, do they have the time to do those procedural steps? Because the reason the person's on the ramp is because there is no
But it would be the
capacity.
paramedic doing those procedural steps. So the paramedic would be the one taking the blood, I assume filling in a form.
I assume
No,
they wouldn't have access.
they're not an employee of the hospital,
Yeah.
so they don't have the right to fill out the paperwork for the patient within the hospital.
From memory, the coroner did talk about this, and they sort of said, well, someone's going to be doing bloods when they get into the hospital anyway. So you're still going to be spending that time doing that paperwork.
Yeah.
So how about let's just do the paperwork at a different time?
But that nurse, when they do that paperwork, has then assigned themselves to that patient and has that capacity to do that at that point in time that they may not have the capacity.
Yeah, because they're dealing with other patients.
And that's why that patient's sitting outside in the first place.
Yeah.
And so,
gotcha.
Don't get me wrong. Again, with the, I agree, let's just trial it. But I can see how some of those logistics would be challenging.
Yeah.
But I feel like the logistics that can be worked through in some way, but it'd be trial and error.
Yeah, and that's the thing. I can't immediately see an answer to it, but it doesn't mean that there isn't one.
Yeah.
Several issues related to patient deterioration while ramped were raised in the inquest. The first was the training of paramedics to detect slow deteriorations and being able to escalate them. So as we mentioned before, while paramedics are very skilled, their main role is to stabilize patients and transport them to hospital rather than monitor them over extended periods.
Yeah. I was going to say, how many paramedics previously would have like actually spent hours with a patient?
Yeah.
Versus
no one.
Yeah,
never.
like except for when you're like out rural and have to drive a
Yep.
really long way, but like outside of that,
Yeah, it's
you
normally
probably,
quite quick.
Yeah.
There are also no specific timeframes for paramedics to record observations of ramped patients.
Right. Versus like once they hit
Once they're inside.
there's like mandatory how many times per hour you must do
Yep.
observations type things.
Yeah, that's right. And if a paramedic does detect a deterioration, they are at the mercy of the triage nurse who makes all relevant decisions. So they can raise it with the triage nurse that there's been a deterioration, but at the end of the day, the triage nurse has the power to either bring them in or say, you need to wait.
So something objective or some sort of criteria that then makes it, again, also reduces that burden from that triage nurse of like, hey, they've hit XYZ number. That means that you have to, do XYZ adjustment rather than that like gut feeling of I think they're deteriorating and that nurse being like, are you just trying to push the line?
Yeah, because you want to do your break or you want to get back out there and help more people. Yeah. There are no or insufficient emergency buttons in the ramping area, which means that paramedics have to walk into the hospital to speak to the triage nurse.
Yeah, that again with the like, I don't understand how there's not like an easy communication method available to them.
Yep. And the third issue is the time taken to offload a patient from the ambulance and transport them into the emergency department, which typically takes at least a couple of minutes. Which if someone is seriously deteriorated, that is our
but
precious
they often,
minutes.
Yes and no though, because like I mean they bring people in that are having active CPR, like.
Yeah, but they're going...
That's not necessarily... Like, ramping doesn't change the fact that it takes time to get someone out of an ambulance into a hospital.
But if they were somewhat well when they were offloaded and it wasn't super emergent, and then when they were in the hospital, that's when they deteriorated, you can still get to them sooner.
Yeah.
You can start doing... You've got all of
stuff they're already in
equipment.
Yeah, fair.
In response to these issues, the coroner made recommendation 7. South Australia Health should introduce a statewide policy and or protocol for dealing with patients who deteriorate in the care of paramedics while waiting for admission to an emergency department. This policy should recommend observations by paramedics at minimum regular intervals, subject to clinical judgment, and would ideally contain a colour-banded chart with specific actions required depending on the results, which is what you said, Georgie.
Oh, okay, cool. Look at me.
Nailing it. The protocol should set out who is responsible for dealing with the deterioration on the hospital's behalf and what should be done. The protocol should endorse escalation in any circumstance where there is clinical concern, whether it meets the criteria set or not. So internal ramping was discussed as a possible solution, and it was noted that this is the standard for Victoria and Queensland.
Would that not just create crowding?
Yeah,
yes.
It's people in the corridors.
Yeah. So
and then you have to see someone in the corridor. I have no idea how hard it is to assess someone in a corridor.
Yeah.
For so many logistical reasons, along with privacy
reasons.
Yeah, absolutely. So, but then the coroner interviewed a whole bunch of people and said that the number of patients who are ramped wouldn't be able to fit within the layout of the metropolitan emergency departments in South Australia. So they said, no,
it's actually just
we're not doing that.
Pros and cons, they haven't built the corridors wide enough for that, which is great that they can't do it, but then I have other concerns.
Yes. So because of this, some hospitals in Victoria have the solution of creating a specific area of the hospital where patients brought in by ambulance can wait with paramedics, and that's somewhat similar to the Q zone of the Lyle McEwen Hospital. So something like this would have multiple benefits. One paramedic crew arriving with their patient could transfer care to another paramedic crew who's already there with their patient. So you then free up one.
Yeah.
Providing everyone's at an okay enough stage to be able to have 2 paramedics with 2 patients. Obviously, that's not going to be suitable in all cases.
Yep.
But you've got one ambulance that's free.
Yeah, okay, the resource. Okay.
Yeah.
Resource argument I can see. Okay.
Yeah. Patient care could be transferred to nurses, again freeing up the ambulance. And nursing staff would be able to easily and safely take blood samples from patients.
Sure. Yep. Really keen on the bloods.
Yes. The hospital would need to make sure that this area is used as intended rather than just becoming another place to put admitted patients.
Easier said than done.
Yeah.
Because when your hospital's full, like, what's the plan?
Yeah.
But realistically, so then if you've got patients that are just waiting to go to a ward that are relatively stable and not needing care, why would you not put the stable patients there and then your newly arrived that you've not even assessed, that you have no idea are stable or not, into a bed? So like really, I argue the opposite of like, no, it should be where the admitted patients sit and chill.
The ones who, yeah,
who
if
you know
you've
are
got
gonna
any
sit
who
and
are
chill.
waiting for beds, yeah. So this led to recommendation 8 that an ambulance waiting area should be constructed adjacent to, but not within, the emergency department of each metropolitan hospital, which has experienced significant periods of ramping. These areas should be fitted out with appropriate equipment and supplies familiar to paramedics to allow for patients who are unable to be immediately admitted to the emergency department to wait in the care of paramedics, ambulance officers, or nurses outside of the ambulance. These areas should be fitted with appropriate emergency buttons. Policies should prevent the use of this space by the hospital other than for visualization and other triage processes by triage nurses, intake blood samples, and sudden resuscitation level events.
I have so many comments. Okay. Has this coroner been into a hospital?
Yes. So really interestingly, for this inquest, the coroner went to all of the major metropolitan hospitals in South Australia and like observed them, I think, over the course of hours.
Okay. Where is he putting this? Because that's
Oh yeah, no, that's
a room that like the building doesn't facilitate.
Yes, so they would
currently
need to build
somewhere.
Yes, they would need to build an extension.
An extension that specifically extends to the emergency department, which Flinders Emergency Department is built on a hill, so like that would be off a cliff.
Yeah, so that's actually the next recommendation is to do with Flinders Medical Centre, which is old, too small, and the emergency department is not on the ground floor at Flinders.
Yes.
Which I think one of the witnesses was like, I wish they had not put this emergency department on an upper floor.
Yeah, it doesn't make
Why
any
did
sense.
they do this?
You have to drive up a ramp to get to it. Yeah. So just like where does one put this? Must be stocked with stuff that's used by paramedics, but it is being stocked by the hospital, not the paramedics. So how is the hospital to know what it is that the paramedics are using?
Logically, the paramedics have a standardized, like the ambulance service.
But they're
would have
two
a
different
standardized-
services.
Yeah, I know. But
So like the hospital doesn't know what that service does. So,
yeah, but they should
and
talk to each other.
They should. I agree. When the ambulance changed to, today we're using the blue tongue depressor and tomorrow we're using the red one, then that communication needs to also happen to the hospital.
Yep.
Is that ever going to happen? And if they keep changing stuff, is the hospital going to be like, well, we've still got 7 blue tongue depressors here, so we're not going to buy you red ones until you use these ones up?
Yeah.
Like,
there are definitely
questions.
logistical.
I do appreciate that they're saying that room should be fitted out with stuff, though, because I did immediately be like, that's fine, you just put them in a corner. But, an ambulance has, like, a fully stocked environment of pre-hospital items.
Yep.
Yeah. Each hospital is going to have its own supply of oxygen, its own supply of masks and whatever. So you would also need to define how many particular patients could sit in that space, because if you put too many and you have 30 people with 3 oxygen tanks, or it would be walled, but you know what I mean?
Yeah.
That's not going to work. I have concerns about logistics. It seems great. I think the coroner's being a little over-enthusiastic here.
Yeah, that's fair. Yeah.
Thanks for my rant.
No,
I'm done.
that's fair. No, like they're trying to say this is what the gold standard should be, but it takes time and money and resources and.
But if you're going to build
lot
a
of
whole other
planning.
room,
Just make the emergency department bigger.
yeah, like
Yeah.
is that the best use of? It's still going to leave paramedics unavailable, external to the hospital. Why are we not just staffing the hospital better and having more emergency beds?
Yep.
And like to the point of like, it literally sounds like South Australia needs an additional large hospital.
Yeah.
Like an additional tertiary hospital is basically what we're saying from the amount of ramping that's happening.
Yeah, apparently there's an intention to open a new emergency department in Victor Harbour, and a new women's and children's hospital, which will incorporate a larger emergency department.
But those are not entirely new services.
okay.
They already exist. They're just replacement services in
Yeah.
a sense that it's no longer satisfactory to update the women's and kids. The only option is to create a whole new service.
So recommendation 9 was that a review should be conducted by South Australia Health into the adequacy of the building and facilities of the Flinders Medical Centre Emergency Department to manage its demand and expected role within the health system. The review should identify whether there is any suitable alternative location for the construction of a new emergency department, including consideration of the feasibility of moving it to the floor immediately below, and whether that would allow for improvement of facilities and future expansion.
Man, so optimistic.
Yeah.
I like.
I was about to say,
the
where is all this
optimism.
money coming from?
Oh, well, that's not the coroner's problem. That's the government's problem.
All right.
Coroner's just there to recommend.
Yep.
Recommendation 10, that a statewide policy be implemented that makes clear that the principal duty of care for a patient who has arrived at hospital lies with the hospital, even if the patient is not admitted to the hospital but is ramped in the care of paramedics.
Pros and cons. It's good that the hospital then has to take responsibility. Does that kind of have an impact on the paramedics? Like, not responsibility, but ability to still care for the patient.
I think they would still be.
They would still be
allowed
but like,
to.
does that then give the triage team like the ability to just be like, no, it's our patient now, go away, even though the paramedics are like,
Well, I'm sure the paramedics would be like, please, we'd love to go away. Take them into the hospital.
But they can't.
Paramedics are all for dropping them off and leaving again, but
True,
they
because
just
they are
can't.
pre-hospital services.
Yes.
Mm-hmm.
Yeah.
The next two recommendations were in relation to siloed thinking and the need for the health system to work together.
Yeah.
Recommendation 11. Status board displays should be rolled out with a wider scope than they are currently used. South Australia Health should consider the cost versus benefit to determine the breadth of the rollout. I think that's in hospitals. Some of them have
Displays.
status
Yeah.
boards to say how many patients they've got, how many are waiting,
Yeah.
all that sort of stuff.
Mm-hmm.
Recommendation 12. A statewide policy should be implemented to address the principles of admitting patients to wards over census. It should set out the agreed indicators that trigger a requirement for wards to negotiate to take additional patients.
Yeah. Again, pros and cons to those
Yeah.
of like, sure, we can put more patients on the ward, but if we don't have the staff to do that,
Yeah.
it just makes it unsafe.
Yeah. And we're compromising everyone's care in that ward. Yeah. Recommendation 13 was a review should be conducted into the best manner of achieving an increase in weekend and overnight discharges. This might or might not include negotiating for a mandate or incentivization of rostering across 7 days in the enterprise agreement, covering consultants when it next expires, so whenever that is. It should include consideration of the establishment of SWIFTs across all metropolitan areas.
Yeah.
And they seem like a
absolutely.
really good idea.
Yeah.
So the South Australian public health system is divided into 10 local health networks, LHNs, each administering hospitals within its area. There is fragmentation between the LHNs, with each having its own staffing models, procedures, and protocols.
Yep.
So recommendation 14, a review should be conducted into the LHN structure across metropolitan Adelaide to consider whether there are advantages to incorporating all metropolitan LHNs into a single structure with standardised procedures and a single chain of command, and whether that would benefit the healthcare provided and those who provide it.
Good luck with consensus.
Yes. So the catchment areas for mental health patients do not align with the general medical catchment areas,
Really?
according to this inquest. Yep.
Oh my god. Okay.
And the Royal Adelaide Hospital has the most populous catchment area for mental health.
Mm-hmm.
There is a policy that LHNs must treat all mental health arrivals at their facility until discharge, which means that the Royal Adelaide Hospital has an increased demand for a limited number of mental health treatment spaces.
Mm-hmm.
Because, mental health care, it's not medical care, right? So,
Yeah,
why would it
apparently not.
align with the medical care?
I know.
It's fine. I'm not having a meltdown over it. It's fine.
So recommendation 15, South Australia Health should consider the appropriateness of the mental health catchment areas and whether the mental health resourcing within those catchment areas is aligned to the expected demand of those areas. Particular consideration should be given to the Royal Adelaide Hospital, which receives a disproportionately large number of mental health patients.
This coroner is thorough.
Oh,
Looking at all the different avenues.
Oh, yes.
Yeah, because like mental health doesn't really actually play into ramping.
No,
Well,
except for the
necessarily.
beds.
Yeah, okay.
It does. I can see how
Yeah.
it's connected, but it's a
Yeah.
kind of tangential point.
Yes, and the coroner did say that, like, they're not going to go into a huge amount of detail in relation to mental health care because that's not the scope of this inquest.
Yeah, okay.
But also, they did raise the point that if someone is in an emergency department for a mental health reason, the fact that they're in a really overcrowded emergency department does
Doesn't make it
not
better.
help.
No.
Recommendation 16. South Australia Health should explore the expected benefit to the introduction or expansion of 24-hour transit wards, accommodating patients of various levels of mobility at the major metropolitan hospitals.
Sounds
Fairly
reasonable.
self-explanatory. Yep. It came up in the inquest that after the deaths of all 3 individuals, adverse incident reviews were completed, but none of the clinicians directly involved in their care were involved in these reviews. The coroner also found that there were factual inaccuracies in the reviews, which contradicted both the medical records and the evidence given at the inquest. So, recommendation 17.
So who did the reviews?
Other clinicians looking at the medical record only.
Yeah, okay.
Yes. So, recommendation 17. South Australia Health should amend the clinical incident management policy to include a requirement that clinicians directly involved in providing care are offered the opportunity of providing information to the reviewers on a no-fault basis, and including a process for those involved to be notified of the outcome if they wish.
That I strongly advocate for. Debrief and follow up for clinicians that are involved in horrendous days at work. These reviews and those outcomes provided to those individuals.
Yeah, right.
that
So
are
the
involved.
outcome might lead to like a policy being changed or something, some other change, but the person who's actually involved.
But I specifically think, if it's a written report, that's fine. You can literally be like, do you feel comfortable with it being emailed to you? Or
Yeah.
would you prefer to come in and have a verbal conversation? Because some people getting a random email 12 months later of some incident could be triggering. So you
Yes.
might want an alternate option. But for some
Yep.
people, it might just be like, yeah, in a time that I am feeling okay with it,
Hmm.
I would like to read from A to Z
What happened?
how that whole event went down, because you're involved in a minute portion of
Yep.
the overall
Yeah.
system.
Yep.
And so specifically having a list of people that this needs to go to would be incredibly important.
Or even just, giving the clinicians the opportunity to say, yes, I would like to hear more about this when it's finalised,
Yeah.
or no, I never want to think about this ever again.
Yeah.
So there was also a small mention in the inquest of the wording used when people call 000 and aren't likely to have an ambulance attend quickly. So an expert witness stated that saying, quote, "We are experiencing high demand for emergency services," end quote, may not get the message across that an ambulance is not coming. That you need to say something
That's
like
fair.
significant delays or some other language that's a bit more plain English. So recommendation 18, the South Australia Ambulance Service should review the accessibility of its scripting in situations where there will be a significant delay in the arrival of an ambulance to ensure that it makes the fact of delay clear and provides examples of alternative options.
And implementation of that kind of information is incredibly important to people, because it gives them the opportunity to consider alternative options. If, as much as, we sit around and say, if you need an ambulance, don't drive yourself.
Yep.
Sometimes if there is no ambulance coming, your only option is to get yourself there.
Yeah, maybe a family member drives you, a friend drives you.
And sometimes that is actually the better alternative than
Yeah.
waiting for an ambulance, if you have been informed that the ambulance is probably going to be delayed.
Yep.
So as we've already heard, that's very important.
Interesting. Like, I think it's, a very important recommendation, but how relevant is it to this scenario?
It's not
overly.
No,
Not really.
it's more just
Yeah.
like it was a very small mention at the
Yeah.
end of the inquest. So, like, final recommendation is just maybe make your scripting easier to understand. Not relevant to this case in terms of it's not going to directly,
but
not necessarily,
But this is
would have
Skeffington
changed
had
this.
4 ambulances that got cancelled.
that's true and got redirected for,
Therefore, his wife might have been able to drive him. He was elderly.
Maybe. Yeah, he was,
He was
89.
But he may have had family members, or
Yeah.
he was in a retirement village or something
Yes,
that
he was,
other
yeah.
people might have been able to facilitate the transport, because
Yeah.
it sounded like at the time that they first called, he wasn't so particularly unwell that
He didn't need emergency treatment right then, but he did need treatment of some kind. Yeah. So that is all of the coroner's recommendations, all 18 of them. This was a very thorough inquest. I did
Absolutely.
like the fact that the coroner actually went to the hospitals to
Yeah,
get a
I find that
sense
interesting.
of actually
feel.
how they work. Obviously, they don't know exactly how they work, but get an idea of the circumstances in them, how they felt,
Yeah, right.
what the levels of
And I guess because
busyness
this is
were.
such a sensationalized inquest,
Mm.
it probably was necessary to then make sure that they've been that thorough.
Which is interesting you say it's sensationalized, because I agree, and it's a very thorough inquest, and it sounds like there are a lot of systemic issues that needed to be, teased through and things like that. But ultimately, the deaths that led to the inquest
And not
weren't
nearly as sensational as I thought they were going to be.
they weren't as
Yeah.
shocking as I thought they were going to be. So I think that's just very interesting, because obviously I've heard of the ramping issues and things like that as being sensationalized in the media. But when you actually go through the actual deaths in the coroner's inquest, you're like, okay.
What would have changed significantly had there not been ramped?
Yeah.
Except for maybe the third case, I'm not convinced that much would have changed.
Yeah, essentially, Mrs. Pennella was not preventable. Her death
Yeah.
was not preventable.
Yes.
The second one, Mr. Skeffington,
Possibly.
Possibly, but also he was very
Yeah.
elderly. Yeah.
he wasn't. Oh yeah, no, he was. Yeah,
he was elderly,
89.
but he was
yeah.
pretty well
True,
otherwise.
yes,
so
yeah.
functionally
Mm-hmm.
versus Mr. Jessett was pretty unwell.
Mm. Yes, long inquest,
Mm-hmm. Thorough inquest.
lots of investigation, lots of witnesses. Interestingly, and the coroner sort of noted this at the end, the Nursing and Midwifery Federation of South Australia did not cooperate in any way with this inquest.
That's really unhelpful because of the triaging situation
Yeah.
where it's very important.
Really impacts them.
So
Mhm.
I'd love to know their decision making behind why they weren't
Yeah.
willing to cooperate.
Yeah. And there was a quote in the inquest. It would be most unfortunate if they were to seek to oppose any recommendations after they have been made. Essentially, like, we asked for your input. We asked for you to
Yeah.
cooperate with us, and you said no. So
Yeah.
for you to turn around and
Be like, I don't agree
oppose
with
our
that.
recommendations
That looks
is not.
really bad on an organization like that to not cooperate with what is meant to be.
Something to improve.
Yeah.
A system
Yeah.
improvement process.
Yeah.
That's really
That directly
disappointing.
impacts.
Yeah.
Yeah.
I would love to see them issue a statement as to why they were unwilling to participate in a coronial inquest.
Yeah, and it's interesting because the coroner did mention, they said, I note now with frustration and disappointment, to say the least, that the Federation has chosen to make public statements on important issues about ramping, both internal and external, and its effect on their members. I cannot now consider nor act on their reported issues revealed publicly on the 16th and 17th of July, 2025, because this was released on the 31st of July.
Mhm.
Right, okay.
So after essentially the inquest had wrapped up,
Yeah.
but shortly before it was released,
Yeah.
the Federation did make public statements about ramping, but the coroner then couldn't take them into account at
too
all.
late.
It's like too bad.
Yeah.
That's interesting.
Hmm.
Yeah, wow.
Maybe they thought they were protecting their members.
It's not like they were in any way contentious.
Yeah, they weren't being painted in a bad light at all.
Yeah, no, the coroner did specifically say that they do not hold anyone responsible for these individual
Exactly.
deaths. Like, none of the clinicians or the
Right.
medical staff involved did the wrong thing at any point. This is
yeah.
a systemic issue that led to these
Yeah.
deaths.
All right, thank you very much.
Thanks, everybody, for listening. We will catch you again next time.
This is our last one for the year, I think.
Yes, it is. We will catch you again in February 2026.
That's great.
See you in 2026.
Bye.